Hey everyone, Dr. Ryan here, and in this case presentation video sponsored by Colgate, I'll be talking about the orthodontic treatment that I provided for Nakib. So Nakib came to my orthodontic clinic after receiving my ad in the mail, and he wanted a few things. He wanted his bite fixed and his teeth straightened, and he also mentioned that he feels like his chin protrudes. Nakib never had orthodontic treatment before seeing me. For some health history, Nakib is a 24-year-old male. He has seasonal allergies. He takes Retin A, which is tretinoin, a topical cream used for acne, and he sees his dentist every 6 months for regular cleanings. This is also really subtle, but if we looked at the facial profile here, notice how he tucks his lower lip back in the profile view. I think this is a subconscious adaptation to try to hide his class 3 mandibular prognathism. It's kind of like if someone's class 2 and you take a profile photo of them, you might notice that they tilt their head back a little bit to help protrude that retrognathic chin. It's also like if someone is asymmetric and you take a frontal photo of them, they might slightly turn, look at the camera at a slight angle to try and mask their asymmetry. So for the intraoral and extraoral exam, there was no significant facial asymmetry. His oral mucosa was fine, no lesions, masses, or ulcers. His gingiva also looked good, dark pink color, knife edge margins, and a little bit of stippling. Lips, tongue, vestibule, oropharynx, all within normal. He did mention to me he gets frequent aphthous ulcers, which we did deal with throughout treatment a little bit, but at the time of his initial presentation, we didn't have any, and salivary glands without swelling, masses, or obstruction. So here's the initial intraoral scan. He does have a little bit of calculus accumulation on the lingual surfaces of the mandibular anterior teeth, where the sublingual and submandibular glands empty. There's also a good amount on the facial surfaces of the upper right posterior teeth here. Interestingly, that's where the parotid gland empties out. So where that saliva is being provided, it's bringing mineral content that is mineralizing the plaque that sits on those teeth. Also notice that he has some sealants on those lower sixes. So he is class 1 on the right side. He's class 1 on the right side, but on the left side, he's a good half cusp class 3 for that dental malocclusion. Half cusp, we got those teeth basically sitting on top of each other, and the lower is too far forward. He also had a bit of a forward functional shift. You can see those canines are primarily to blame, those lower canines, because they're an anterior crossbite. So he's hitting more edge to edge in the front, and then his canines would make everything kind of shift forward to fall into a maximum intercuspation position. There's also a buccal posterior crossbite at the right 4s and 5s. So these upper teeth were sitting completely outside the lower, and you can see also in the upper scan how much facial displacement there is of those teeth. And again, just to be clear, a buccal posterior crossbite is not like a lingual crossbite, which we typically think of with crossbite. Buccal or Brody bite, that means the upper teeth completely hang outside of the lower teeth. So the buccal and lingual cusps are both visible. And with regard to the incisor overlap, he does have a moderate deep bite. Here's the initial pan. We have some impacted right 8s, right wisdom teeth here, and he did have some inflamed gingiva around the left 8s. Otherwise, bone looks good, roots of the teeth look nice, so no other concerns there. So for treatment outline, past medical history, no contraindications to treatment. Dental history, again, no contraindications to treatment. Glad that he's seeing his dentist regularly every 6 months. Growth, post-adolescent with minimal remaining growth potential. I did include an asterisk here because we do have to be wary of class 3 growth, which can continue even into a patient's late 20s. especially if they're mandibular prognathic. So that's definitely something to keep in mind. And as a rule of thumb, individuals with mandibular prognathism are particularly prone to continued mandibular growth due to the underlying genetic and skeletal influences that drive that class 3 pattern. So total problem list, we had moderate upper crowding, severe lower crowding. He's class 3 skeletal with mild mandibular prognathism, and class 3 dental, as we talked about, on the left side, so we could call it subdivision left. Did have a forward functional shift because of the anterior crossbite of the lower 3s, buccal crossbite on the right side, and a moderate deep bite. He was not interested in braces, and I was happy to do Invisalign aligners and elastics with him, and my estimated length of treatment was 14 to 18 months. So here's part 1 of the treatment timeline. We started in December of 2022. We bonded his attachments, delivered the first batch of trays. I usually give the first 5 aligners as sort of the acclimation phase. You could call it a trial period where we're just getting used to everything, and I want to check the patient back sooner rather than later just to make sure everything's tracking well and the patient doesn't have any issues. I usually also wait until that time before starting any rubber bands, but because of the severity of his bite malocclusion, I did decide to get hooks on there. We use Kaplan hooks, which I'll show you in the progress scan in just a second, to begin cross elastics for the crossbite on the right side and class 3 elastics on the left side. I did do some IPR at that next appointment, so polishing in between the lower teeth. And then basically what I do is I deliver about 8 weeks worth of trays at a time. And I like to see the patient back pretty routinely when we're doing elastic stuff, just to make sure that nothing is going too off track or the rubber bands aren't overpowering the plastic of the aligners. So I do check these patients back a little bit more often than an aligner patient who doesn't wear rubber bands. At June of 2023, I decided it was definitely time to do something about the wisdom teeth. When we're doing class 3 correction, especially we're trying to move everything distally on the bottom, those wisdom teeth are going to make things very, very difficult. And so it was time to get those out. He was reticent at first, and I kept telling him, if we really want ideal bite correction, especially that lower left 8, that's going to have to go. And so gave him some passive aligners to hold him in that current position, and we got the wisdom teeth extracted on the 23rd. And then after which we did a refinement scan and we kept going. But I do want to show you the progress scan that we took at this point, the refinement scan. I think the progress at this stage was incredible. So this was, keep in mind, he started in December. This was end of June, so about 6 to 7 months. And this is what he looked like. So remember, he started here with crossbites, class 3s, and anterior crossbites, a ton of crowding, and this is where he was in about 6 to 7 months. So the upper arch, I was thrilled with the progress. And again, this is 26 active aligners. And so the upper arch taking a really nice U-shaped arch form. I did open some temporary spaces distal to the upper 2s to help establish that overjet and correct the anterior crossbite sooner rather than later. You can see how much better these upper right premolars look after the buccal crossbite was fixed. Pulling on the Kaplan hook here to the Kaplan hook here was helping to provide some lingual force on this segment, so helping to correct that crossbite nice and efficiently. On the left side, we were running a class 3 elastic, and so there was a lower left 3 precision hook built into the aligner, so it's a little slit right in the aligner, and then I was having him hook it up to a lingual Kaplan hook on the upper left 6. This was to provide a class 3 force vector, but also a slight facial force as well as we were correcting that class 3. I wanted a little bit of a facial vector as well, as opposed to putting the Kaplan hook here. It would be a little bit easier for the patient to hook up, but then you get a slight lingual force vector, which I didn't want. So anyway, great progress here. And we had to, of course, keep going. We had some more work to do. We did another set of trays here. This one was 1 through 24. The upper left 2 wasn't tracking super well during this round, and I'll just say upper 2s across the board are notorious for not tracking too well with aligners because they're smaller teeth, they're next to some really big teeth, and so there's less surface area to grab onto, and it usually just makes those teeth a little less predictable when moving with aligners. We did scan a second time, delivered some more trays, and you can tell as we went on here, the total number of active trays each time got less and less, which tells me we're getting closer and closer to the end result. Now, you will see here that I did end up replacing that lingual upper left 6 hook with a buckle hook because it was a little bit difficult for the patient to hook up to, and eventually I had a good position buccolingual of that tooth, no longer needed the buccal force vector, and said, hey, let's just make it a little bit easier for the patient to continue that class 3 elastic because that AP force vector was much more important at that stage. Unfortunately, 2 weeks later, the upper left 6 hook came off. We just had to rebond that real quick. I think that was the only comfort appointment this patient ever had, which is pretty impressive. And we did another refinement scan, final round of trays, and all looked good at that point. And so in total, that was 15 regular visits, 1 comfort appointment, so a grand total of 16 visits. At the removal appointment, we took all the attachments off and the hooks off. I did do a little enameloplasty of the incisal edges to make everything look nice and even, and then we scanned for clear plastic retainers. I did really want the patient to do a lower lingual retainer. He didn't want to have that just for ease of cleaning and maintaining good oral hygiene, but with the severity of the crowding, I did recommend it. And also, to be honest, I gently recommended the upper arch because anytime we extrude teeth, like we extruded his upper laterals a little bit, that movement can be very tough to retain with a clear plastic retainer because you don't really have the retentive quality. The plastic will fit over the teeth well, but there's nothing really holding that tooth in the extruded form. It can just kind of intrude slowly with time. So I do like the bonded lingual retainers for that as well. But again, he wanted the clear plastic, and so that's fine. I just let him know the potential consequences of that. I did underestimate my treatment time for Nakib just slightly. I said 14 to 18 months, and this turned out to be a little bit over 18 months long. And I will just say, as a general rule of thumb, anytime you're aiming for bite correction in an adult patient, always plan on it taking longer than you think. It's unpredictable, and it just takes biologically a long time for the teeth to move that way, for the TMJ to remodel and all of that. It can just take a long time. So anytime you're doing class 2 or class 3, if you're attempting beyond a half cusp, that's going to be very, very tough. That's when I start thinking about doing some extractions and things of that nature. But for half cusp or less, will be tough, can do it with elastics, but need really, really good compliance. Fortunately, Nakib was really, really good, especially at the beginning with compliance. He was absolute rock star. So here is the final intraoral scan. I'll point out a couple things that I didn't like with this final result. I'm being really nitpicky here, but I do like to critique my finishes. The midlines are slightly off, but we have a rule in orthodontics. Sometimes perfect is the enemy of good. In other words, insistence on perfection can lead to endless treatment times with little to no payoff and could contribute to other issues or other problems where you start opening a can of worms. We're trying to chase this midline and then we throw off something in the posterior, for instance. And so sometimes you're within that 2 millimeters where the layperson won't even notice. So that's one of those things that I don't think is worth losing sleep over. You'll also notice from the side view, the lower incisors are a bit retroclined. Now, this is part of dentoalveolar compensation for a skeletal class 3 patient. So I am okay with that. Of course, it's not ideal, but I am okay with that given the patient's skeletal malocclusion. There's also a little bit of a class 3 window between the upper left 3 and lower left 3. What that's caused by, that's this little space you see right there. What that's caused by is some extra lateral overjet. You don't really have that on the right side, but we do have a little extra lateral or canine overjet on the left side. But to be honest, that's okay. Patient doesn't mind at all. The alignment's absolutely beautiful. His bite looks a heck of a lot better, and so we're okay with something like that. Again, I'm just being overly critical of my result here, but patient was, of course, super thrilled, and so was I. Here's the final pan, by the way. This was taken in June 2024, and you can see the wisdom teeth were removed, all 4 of them, which I did recommend because of the issues they were causing. And the roots are also fairly parallel of these finished teeth. And you know, yes, this tooth isn't quite parallel with the adjacent ones, for instance, but with Invisalign, you don't have the best root control. And so sometimes we just have to accept root positions not being 100% perfect. And again, that's okay. And so here is Nakib's finish: before on top, after on the bottom, before on the left and after on the right. And what's fun with these big transformations where a patient's never undergone orthodontic treatment before, has kind of dealt with this all their life and now have a beautiful new smile, you can see someone's confidence in the way they smile. They're kind of hiding everything here, not smiling really big, and then smiling really big, showing the top and the bottom teeth. That is a sign of a happy patient right there. So it's fun to see the effects of your treatment go beyond just the clinic. So thanks so much for watching this case presentation. I hope you found it informative, and I'll see you in the next one.